طيب السلام عليكم. أهلا بكم جميعا، مساء الخير. وهنبدأ مع cardiac emergencies. Just tell me that you know my voice is clear and I'm going to proceed.
واضح دكتور حاتم. مساء الخير.
مساء النور وأهلا بكم جميعا. Just I want to show you what we have done so far and the schedule we have agreed on. The chest X-ray was our initial presentation or session, then followed by basics of echo, coronary angio, all done, right? And I'm so proud that you have participated in our annual course. And today we're gonna discuss cardiac emergencies. Next will be exercise ECG. So according to our schedule, we are missing or we have skipped invasive hemodynamics by Dr. Yasir Ahmed. And I agreed with him that he is gonna catch up on that later after the exercise ECG, okay? So far so good, Yani, and I think we are on schedule. We are not missing a lot. Now, when I'm going to talk about cardiac emergencies, I have to define what is the medical emergency. What do we actually mean by medical emergency? There are so many definitions of medical emergencies. I have pinched out few. Medical emergency is an acute injury or illness that poses an immediate risk. Okay, let me mute. Okay. That poses an immediate risk to a person's life or long-term health, sometimes referred to as the situation risking life or limb. Okay? Life or limb threatening situation. It's the sudden onset of a medical condition manifesting itself by acute symptoms of sufficient severity, including severe pain, such that the absence of immediate medical attention could reasonably be expected to result in placing the patient's health in serious jeopardy, serious impairment to bodily function, or serious dysfunction of any bodily organ or part. This is broader, but more or less the same as the first one. An unforeseen combination of circumstances which calls for immediate action. Now, this is more of emergency in a generic terminology or in a generic kind of definition. And it encompasses or it includes all type of emergencies, not the medical only. So emergency in general is defined as unforeseen combination of circumstances which calls for immediate action, whatever that emergency is. Okay, disaster, natural disaster, political emergency, wars, medical emergencies, and all. A medical emergency is defined as a medical condition which endangers life and or causes great suffering to the individual. So it's not necessarily life and limb, but even if it suffers the individual in subjective ways is considered medical emergencies. Now, from this definition, you probably have the feeling that there are no kind of unanimous consensus around the definition itself. But the most adopted definition of emergency is any kind of a situation that threatens life or limb and calls for immediate action. Okay, so emergency room by definition is a place where you have to sort out which is life and limb threatening condition and employ the immediate measures. And after that, the emergency will be extinguished, the emergency situation, and the patient can be treated as inpatient, outpatient, or whatever. Now, do you know this, codes and colors?
Not all of them.
Yes.
I think code
Yes.
black, code below.
Yes. So code black and code blue. Good. طبعا there is differences between hospitals, but يعني it's more or less conventional that the code blue is cardiac arrest and code red is fire, code black is bomb threat or disasters sometimes, stuff like that, okay? So these codes are always in the hospital. And the code means what? Why should we codify a certain situation? Is it just for the sake of being colorful, or it entails something more practical? Exactly. And that is?
For the emergency most likely.
إنه الحاجة دي معروفة يعني worldwide in every hospital in every
Yes.
center in every country. يعني once you hear the code,
Exactly.
you know what is the meaning of it.
Exactly. Yes. So it's about alerting a system. So when you announce a code, say a blue code, you are actually activating a system. A system will automatically be activated. So it's not about code. It's not about color. It's about system behind the code. So it is so meaningful practically. When you press code blue or you announce code blue, okay, that will alert certain staff to run to bedside, do some stuff, and employ certain measures. The same applies to any code. So any code is an actually systematic response. Okay, good. Now, how timely you intervene? We hear about emergent intervention, urgent, and elective. What's the difference between the three? Emergent, urgent, elective.
Emergency, you need to act immediately without any delay.
Okay.
For urgent, you may take some time, 2 hours, 1 hour, like this. Yeah,
Okay.
you have and for the elective, you have the time to prepare yourself.
Elective is more or less the time is deliberated or consented by the patient and the physician. Okay, and the system. So you can do lab chole electively within 1 month, 2 months, 3 months, according to the system accommodation, according to the physician and the patient's agreement. Now, emergent, you have to act immediately, like right away. And the response is expected within hours. Now, urgent, there is a difference. Urgent, up to 48 hours is considered urgent. If you say, I want to do urgent PCI, like a non-STEMI, up to 48, 72 hours is considered within the urgent time span, okay? Now, cardiac emergencies, believe it or not, and probably have been through so many, are few. And we have, let me know if you have any other in your mind apart from the one I listed here. Acute coronary syndrome, decompensated heart failure, arrhythmia of all forms and manifestations, tamponade, and acute aortic syndrome. Do you have any? Do you have any more?
Pulmonary embolism ما تبع emergencies.
في السودان تبعكم مش كده؟ في السودان خدتناها تبعكم اظنها هي والدي في تي. Okay, حتى أنا sometime in the private practice, sometime here they send patient with PE to me, and they send patient with venous thrombosis, varicose veins, and considering that I'm cardiovascular. لكن no, usually PE, DVTs, and stuff like that belongs to other domains, not cardiology. Okay. Let me know if you have any additional emergency in your mind apart from these 5. No, sir? They are embarrassingly few. You know, فيعني في الكارديولوجي ما عندنا emergencies كثيرة لكنها broad. Why did I say broad؟ لأنه each and every one of them branches into so many presentations, manifestations, that entails technology utilization, rationalizing resources, algorithmic way of analysis. يعني الموضوع ما سهل. Okay? يعني acute coronary syndrome بيشيلك إلى مكان. Decompensated heart failure, arrhythmia, so many types of arrhythmia, tamponade. Now acute aortic syndrome, that belongs to cardiology and partially cardiac surgery. The acute aortic syndrome includes what?
Aortic dissection.
1, 2.
Infective endocarditis may be involving the ascending aorta, لكن دي بتكون مع الفالفز طبعا.
Yes.
I think dissection is the most important.
Yes. Aortic aneurysm, no, unless it's leaking.
Or thrombosis.
If it's leaking aneurysm, it includes into the acute aortic syndrome. But if it's an aneurysm, that's a chronic. It's not acute. Acute is dissection, aortic hematoma, aortic ulceration, and leaking aneurysm. Okay, so these are the acute. And why acute? Because the presentation is acute, and they can lead to acute kind of repercussion, clinical repercussion in terms of shock and bleeding and ischemia and CNS manifestation and all of that. Okay, so there are 4. Dissection, we know dissection so well, but we are not so familiar with hematoma and ulceration, which present exactly the same as dissection in so many aspects. Okay, and the management is kind of the same if it's type A or type B, and you deal with it accordingly. Okay, so in this session today, we are going to discuss the first 4, but the acute aortic syndrome, we are going to discuss it in the second intermediate cardiology module. Types of PCI and how to impact the prognosis. Now, by now you know طبعا the terminology and this cardiology jargon you all know so well of. When we talk about primary and elective PCI, primary is for what? Primary PCI is for what?
Still elevation MI.
Yes, and elective is the rest. Now, can you give me an estimation of each clinical outcome weight of primary PCI versus elective PCI? Which one is more important? Which one you should invest more? And which
Primary.
one we are doing more? Yeah, primary. Which one we are doing more? In cardiology centers, which one we are doing more?
Elective طبعا.
Elective, exactly. Elective is more. ولكن in terms of outcome and benefit, primary PCI is undisputably beneficial. ولكن elective PCI بدينا شوية كده يعني يكون في some doubts about the robust outcome of elective PCIs, especially after there are 3 trials are important, and I wrote them here so you can refer to them: Courage, CARP, and ischemia trial. Okay, all the 3 were negative trial as to the elective PCI. The last one was ischemia trial. And although there is a lot of criticism around it, ولكن it was negative. يعني elective PCI added no benefit on top of guideline directed medical therapy. The same applies to CARP trial, and the same applies to Courage trial. So elective PCI is doubtful. Primary PCI is undisputably beneficial. Okay. Now, do you know this risk scoring? This risk scoring. What is it?
for chronic stable angina, chronic coronary
Mhm.
syndrome.
Very good. Chronic coronary syndrome. Okay.
Yes.
And
Yeah, Gigi.
what does it do? Yani, this scoring system gets you into what?
The likelihood
If
the
you
likelihood of symptom related to the
very good.
yeah.
Yes. So the so-called pretest probability. So
Yes,
the
great.
pretest probability, before you initiate any workup, any testing, what is your probability of coronary
To get-
artery disease? That is called, exactly, it's called pretest probability. Now, the pretest probability is important because it rationalizes the workup. So not all patients should indiscriminately go for non-invasive testing or invasive testing. So it depends. So that's why you have to categorize or risk stratify your patients into one of three categories: low risk, intermediate risk, and high risk, according to age, gender, and the characteristic of chest pain. So if the patient is mild or low risk, you can just apply preventive measure and proceed no further. If patient is high risk, probably he is best served invasively. If patient is intermediate risk, this is the type of patients in whom you wish to go non-invasively and do further imaging testing and stuff like that. Now, I want your criticism of this scoring system. Look at it again and tell me, you think it's okay, it's adequate, satisfying, and you are happy with it?
It does not include other risk factors.
Exactly. Yeah, and this is one of the biggest criticism of this Forrester kind of risk scoring. It depends on age, gender, and typicality of symptoms. It has not included risk factors. Okay, فبالتالي this risk score, although used until today, لكنه is falling short of encompassing the global clinical context. Okay, that's why people are using their own ways of assessment, though it's not consolidated in a specific recommendation, ولكن they are using their intuition and hunch. Okay, like you probably have Timmy score for MI. Timmy score for MI. Look at the Timmy score for MI. It includes age more than 75 given 3 points, between 65 74 2, DM or hypertension or angina 1. This is historical data. Now exam data: systolic blood pressure less than 100, heart rate more than 100, clip class, which define the level of congestion, and weight less than 67 kilogram. Presentation: anterior STEMI or left bundle is given 1, time to treatment more than 4 hours. Now, if you have more than 8, the 30 days mortality is 36%. So reasonable, right? It's reasonable, isn't it? But
Yeah,
it
yeah.
missed,
But
yeah, it missed something you feel is so important, and that's it. And that's what? Something so important for MI and so prognostic. It is kind of time honor measure of prognostication. ECG is mentioned. ECG is mentioned.
Other comorbidity.
Other comorbidities, it's written DM hypertension. Yeah, they mentioned 2 out of many. Okay, I accept that. Don't you think troponin was important to be included in the list?
Yeah, yeah.
Yes, of course. It's so important. Okay. طيب. أنا طبعا I wanted you just to get familiar to this scoring system, and I want to يعني motivate you to be critical, okay, and to apply critical appraisal of whatever you read or you come across, whether that's recommendation, guidelines, trials, and stuff like that. And I wish sooner in the future we are gonna do critical appraisal of clinical trials and how we do that, okay? Here, I'm a part and parcel of the curricular education in medical schools. They teach them about how to understand and how to appraise a clinical trial or a guidelines and recommendations. مهمة جدا إنه الناس تكون critical. طيب نشوف TIMI 4 TIMI risk score for non-STEMI and unstable angina. Age more than 65, more than 3 risk factors, non-coronary artery disease, aspirin use in the past 7 days, recent severe angina, increased cardiac markers. You see, now for non-STEMI and unstable angina, they included markers. In STEMI, they didn't. ST elevation more than 0.5. What's your criticism? Yeah, just like, you know, think out loud. Yeah, and you don't feel shy about expressing your opinion, whatever it is. So look at this score and the points 111. Look on the left side and let me know what you feel.
Doubling the mortality rate with each.
طيب, I tell you my critical opinion about it. The STEMI risk scoring for non-STEMI and stable angina has put the wheat and chaff together and has included measurement or features or data, and given the same point, though they are so different in terms of prognostication. يعني aspirin use in the past 7 days is as prognostic as elevated cardiac markers. That doesn't make sense, does it?
Yes.
ما ممكن صح؟ فرق كبير
No.
بين أنه patient using aspirin in the last 7 days, this is prognostic 1 point. Now, if I find elevated troponin, it is again like the use of aspirin in the last 7 days. And at least cardiac markers give it 2, 3. I might accept that, like in giving 1, 1, 1, 1. That doesn't make sense. For this is one of the critical points again is STEMI score for non-STEMI. Okay. Now, if somebody can read this one for us, if it's clear for you, I want one of you to read it. This is patients with angina and or dyspnea and suspected coronary artery disease. Risk assessment guidelines 2019, reiterated in 2020. So read the first line.
Type risk stratification is recommended based on clinical assessment and the result of diagnostic test initially employed to diagnose coronary artery disease.
Okay.
Evidence class 1B.
Okay. Second.
Type resting echocardiography is recommended to quantify LV function in all patients with suspected coronary artery disease, also class 1 but level C.
Good.
Okay.
Next.
Risk stratification preferably using stress imaging or coronary CTA if permitted by local expertise and availability. Or alternatively, exercise stress ECG if significant exercise can be performed and the ECG is amenable to the identification of ischemic changes. Is recommended in the patient with suspected or newly diagnosed coronary artery disease.
Okay, last.
Class 1, level B. Okay. Last, in symptomatic patient with high risk clinical profile and invasive coronary angiography.
Yes.
Complemented by invasive physiological guidance, يعني لازم يكون معك FFR, is recommended for cardiovascular risk stratification particularly if the symptoms are responding inadequately to medical treatment. And revascularization is considered for improvement of prognosis. The class 1A.
Thank you so much. يبقى from here there are some new points. The use of echo to quantify LV function for all patients suspected with coronary artery disease, I think we all agree on that. Now, the risk stratification, look at this sentence. Risk stratification, preferably using stress imaging or CTA. Alternatively, يعني in the absence of cardiac imaging or CTA, exercise stress ECG. Isn't that new? Yes, it's new. It's new. Yani, we have been taught and we have been through so many recommendations before. كلهم they lump together the non-invasive testing كلها in one category وقالوا use whatever. There is no preferability of one over the other. Here is exercise ECG, CTA, SPECT, PET, CTA, أو coronary CT, coronary CT, CCT. Okay? كلها كانت بالنسبة لنا is okay whichever. لكن الآن لا بقى في hierarchical perspective in the stress testing. So it is imaging or CT. Imaging stress معناته شنو؟ SPECT, PET or stress echo or CTA. That means what? They downgraded exercise ECG.
Yes.
Okay. Do you agree with this downgrade?
Yes, I agree.
Okay. So, okay. طيب. معناته we agree with this downgrade, no problem. The other thing that they have stressed on, I know ICT to be physiological measure or physiological data guided, IFR guided, and this kind of stuff. Okay, now just one of you to read the one was this marking red, only the line marked in red.
Echocardiographic
This one.
assessment. Echocardiographic assessment of global longitudinal strain provide incremental information to LV ejection fraction may be considered when LV ejection fraction is more than 35%.
I want you to tell me, what do you understand from this one? Because this is
we have to use global longitudinal strain pattern to assess the ejection fraction.
Okay. طيب تمام. هي طبعا honestly speaking probably this is the first recommendation to include GLS, global longitudinal strain. يعني الآن global longitudinal strain we hear of it and we practice global longitudinal strain assessment for quite some time. ولكن going into the guidelines was skeptical. يعني people were skeptical to include it in the guidelines لأنه the expertise is not so and the software and the technology of echo might not be ubiquitous to include the software for strain. فكانوا shying away. لكن now they include it. Yes, it's class 2B ولكن هي بالعادة كده it's class 2 then it moves to class 1A then 1 and so. Okay, you've got probably the future of strain إنه it might go into a stronger recommendation sooner. Okay, ولكن الآن it's included as class 2B. Before it was not included whatsoever in any formal guidelines أصلاً. Okay, يعني بيتذكر كحاجة كده you know what والله it's a nicety يعني حاجة جميلة إنها تعملها لكن it's not recommended يعني بس الآن بدو. And they specify an ejection fraction more than 35. Do you know why? لأنه if it's less than 35 probably خلاص that's it. This is prognostic low ejection fraction finish. Like in more than 35 until normal, if you apply strain, you might find that the LV function is even worse than the ejection fraction. يعني the ejection fraction يقول لك 40 لكن the GLS تلاقيه -10 -9. So it's severe depression or decrease in the GLS, though the ejection fraction is in the moderate or mild range. So بيكون ال GLS is more prognostic with higher ejection fraction than lower ejection fraction. Okay. Now, acute coronary syndrome means what? STEMI, non-STEMI, and non-STEMI. The rest are chronic coronary syndrome. So what coronary to call it what? Stable angina or stable ischemic heart disease. كانت nicely pronounced and easy going. الآن بقت صعبة شوية بالنسبة لي أنا صعبة غاية. chronic coronary syndrome صعبة. أنا ما أعرف هم they wanna يعني stress on the fact that they look alike. Acute coronary syndrome, chronic coronary syndrome, they look alike. The pathological underpinning is the same. Okay. يعني بس they just want to cultivate this idea in our mind.
بس هم الفكرة
طيب
يعني بتتحاسب
what
إنه
if
الكورونا سندروم قسموها الأكيوت وكرونيك.
exactly
بس
بالضبط
simplify it لكن
yes
صراحة difficult بس تعودنا على stable coronary artery.
exactly yes وبعدين وسعوها شوية. Now the chronic coronary syndrome is broader. الديفينيشنز بتاعتها شنو؟ stable angina anorexia. Stable angina, the way we know and define, the patient gets chest pain after a precise level of activity or exertion every time. Okay, but that's we know. New onset heart failure with suspected coronary artery disease is considered chronic coronary syndrome. Does that make sense to you?
Yeah.
يعني إذا
Angina.
جاء yes يعني إذا جاء patient with ejection fraction of 25, the first time you see this patient is إنه جاب decompensated heart failure or new onset heart failure, and you find that his ejection fraction, let's say 25, and you suspected it's ischemic cardiomyopathy. This is called chronic coronary syndrome. Why? لأنه once he reached this level of ischemic cardiomyopathy, meaning it has been chronic, it's not acute sort of ischemia. طيب, stabilized symptoms less than 1 year after acute coronary syndrome or recent revascularization. يبقى if the patient underwent revascularization and his symptom is stabilized, this is chronic coronary syndrome. Patient more than 1 year after initial diagnosis or revascularization. Angina and suspected vasospastic or microvascular disease. Asymptomatic with coronary artery disease on screening. The last one is asymptomatic, and for a reason or another, you have done CTA or nuclear or whatever, and you find that he has or she has ischemia. This is considered chronic coronary syndrome. Okay, so we have multiple phenotypes of chronic coronary syndrome, and we have 3 phenotypes of acute coronary syndrome. Okay. This is always an important question, expect to be asked anytime we are discussing acute coronary syndrome. When we are discussing acute coronary syndrome, that will take us to the basics, which is the mechanistic aspects of the disease itself and the pathological underpinning of acute coronary syndrome, which is, I need it to be in 2 words. If I ask you just in 2 words, what's the mechanism of acute coronary syndrome? What
The
will
plaque
you say?
disruption.
Very good. Plaque disruption. Okay. If you say thrombus formation, yeah, it's okay. Because plaque disruption leading to thrombus formation.
Yes.
So that's the event. Disruption or rupture plaque. And that's will take us to the search of why the plaque ruptured. And what does it do when the plaque rupture? When the plaque rupture or cracks or fissure, it will expose tissue factors, and this will activate intensely the coagulation cascade, and a thrombus will form upon the plaque. That's we know, that's clear pathological event. Now, what makes the plaque crack, fissure, rupture, or perforate or ulcerate? Why? It is the intimal crack, the intimal rupture, the intimal fissure, the intimal erosion. Why does that happen? Why?
According to the type of the plaque itself, is it a vulnerable plaque or not vulnerable plaque?
Very good. Yes.
It has
When
a
it's
thin
vulnerable.
capsule or
Very good.
it has a thin capsule or thick capsule, the amount of the fatty deposition, and the inflammatory marker, macrophage.
Very good. Very good. That's great. You've got, then we have the concept of vulnerability of the plaque, and that's new, recently new concept. And now with the imaging technology, we could decide about the different component of the plaque and decide how vulnerable the plaque is. Because now NAS is not interested about what plaque you have. It's not the quantity, it's the quality. It's the quality of the plaque. What type of plaque is this one? It's not about how much plaques are there, okay? For we get vulnerable plaque is important. And vulnerable plaque is briefly or concisely defined as more of fatty core and less of fibrous cap. يعني انت عندك الكومبوننتس بتاعت البلاكس اصلا cells, fibrous tissue, fat, and calcium sometimes. Okay, لكن the most important three components are the cells, the fat content, and the fibrous cap. Now, the thinner the fibrous cap, the more of the fatty lipid core, the more of cells, لأنه السيلز بتعمل digestion للماتريكس by the metalloproteinases, الالوبروتينيسز it secretes, فبتخلي البلاك vulnerable, and it cracks and it fissures and it gets eroded. Okay. Now, once you have a vulnerable plaque, the rupture is more or less called a biological accident. يعني there is no actual prediction as when this plaque is going to rupture. There is a biological accident we are missing here. يعني بالضبط nobody can define exactly the event that leads to plaque rupture. We know إنه this plaque by this anatomical features is prone to rupture more than this plaque with these anatomical features. لكن when it ruptures, this is biological accident. Okay? It's a biological accident. يعني زي لما انت تقول والله يا اخي يعني مثلا يعني drinking alcohol leads to accident, road traffic accident. Yes, it's okay. طيب جابوا لك مثلا a drunk man who had an accident. He had been drinking for so many years, لكن today حصل accident. يبقى معناتها it's not necessarily أنه vulnerable plaque leads to accident. Okay? في other circumstances we don't exactly know هل during that particular day في additional circumstances unforeseen or we don't know, we can't predict, ساعدت في أنه on top of the vulnerability حصل rupture. Maybe yes, maybe no. يبقى this part is still not well understood. Yes, we have known a lot about the vulnerability of the plaque, the components, and لكن في still some missing stuff about it. ولكن أهم حاجة the vulnerability of the plaque and what does it mean, and when the plaque rupture, how it induces the coagulation cascade and thrombus formation ensues. So how do you, when we talk about acute coronary syndrome, and now we talk about STEMI, non-STEMI, and unstable angina. Though the mechanism is the same, mechanism is plaque rupture. So why plaque rupture lead to different phenotypes, different clinical phenotypes, and not one? Why? Why? Isn't that strange?
No, لكن ال ST elevation MI بيحصل due to complete occlusion للcoronary artery أو coronary vessel، والnon ST elevation or unstable angina بيكون partial occlusion. That's
Okay.
why ال ECG بتكون different between them.
Okay. طيب, and the difference between non-STEMI and unstable angina?
ما يقال the leak of troponin. Once it is positive is non-ST elevation. Once it is negative it is unstable angina.
Okay. تمام. يبقى it's about the totality of the obstruction, like the doctor said. This is part, لكن it's not explaining every part. لأنه there are many times, and you probably know that, إنه البيشنت بيجي بيستمي and there is no total occlusion, صح؟ It's not necessarily total occlusion. ومرات non-STEMI and it's totally occluded, unstable angina is totally occluded. مرات حتى stable angina is totally occluded. The acuity is probably one. Yes.
Transmural infarction also
Yes.
diagnosed as ST elevation MI.
Obstruction of
Sorry, again?
the acute obstruction of the vein.
Yes, the acuity of the event has a lot to do. Yes, yes. How fast it happens. How fast. Yeah. And this, we have nothing to measure. يعني هل thrombus formation and the plaque rupture takes few minutes, or a few days, or a few hours? That might be the reason why people have STEMI, non-STEMI, MI, or an stable angina. يعني هي ببساطة جدا, أنا what I want you to get the idea. I just want to confuse you because I want to take you to the brink of medicine, and we stop there. There are so many missing facts. إنه why the pathology is the same, but the clinical phenotype of acute coronary syndrome encompasses 3. So it's not about plaque rupture and thrombus formation, ولكن في other factors, some of which are speculative and we can discuss, some of which are not understood وكده يعني. فده اللي حاجات اللي انتوا ان شاء الله في مستقبل الريسيرش فيوتشر حقكم تفكروا فيها. طيب, تتذكروا في الكورس في محاضرة كانت مهمة جدا بتاع الدكتور عمري عن التايم فريمز اللي هي from first medical contact, from onset of pain, from door to ECG, from door to needle, from door to wire crossing, وكل الحاجات دي. التايم دي time frames are important ليه؟ لأنها أول حاجة it impacts the prognosis. Number 2, it's so important to audit. يعني مثلا إحنا مثلا في المركز بتاعنا مثلا بنعمل audit لأهم تايم اللي هو door to balloon time. أوكي. ليه بنعمل الأوديت؟ لأنه that's what the entire cardiology system should revolve around. The primary PCI is the supreme procedure of cardiology. يعني إذا بطلنا نعمل أي حاجة نعمل بس البرايمري PCI. مهمة جدا. فبالتالي الauditing للتايم ده is important. إذا نحن we are falling below the standard, we have to think as to why. هل المشكلة في الترانسفير of patient بالتالي نشتغل مع السلطات الشغالة في الترانسفير، ولا هل المشكلة في الترياجين في الاي ار رومز بالتالي نعمل حاجة، ولا في مشكلة في الاليرت of the cath staff لازم. This is an important audit, very crucial audit اللي هو time to balloon. وانا اتمنى انه انتم برضه تعملوا الحاجه دي، يعني تعملوا auditing عشان تشوفوا يعني where do you stand and where should you be, and you identify the gap and you try to see why this gap exists. Okay, This is the auditing process. It's all about where are you and where should you be and the gap between the two. Okay. Now, pharmacological therapy is important in acute coronary syndrome. And let's briefly count what is the pharmacological therapy. What is it? Pharmacological therapy for acute coronary syndrome.
Anti-platelet, anticoagulation, lipid lowering agents,
Very good.
beta blocker, and ACE inhibitor.
Very good.
Plus lysis.
But instead of lipid lowering agent, I would say statin. Isn't that more expressive?
Yes.
No, we are not using fibrate, we are not using others. Okay, it's basically statin. Okay, خلاص, that's it. Invasive therapy, it depends. Now, if you have an acute coronary, I mean, STEMI, you have a certain time frame for action. Non-STEMI is a different stable angina. It's a different. Discharge therapy also depends. يعني the patient usually walk out with all the medication you initiated in hospital ما عدا anticoagulation. Okay, the only thing is the ACE. ACE depends on what? ACE depends on
function.
Thank you so much.
Fraction.
Depends on the ejection fraction. So, can you go further?
If it is less than 40, according to the last guideline,
Very good.
it is class 1, yes, to give ACE inhibitor.
Yes.
Right.
يبقى statin, dual antiplatelet, nitrate for all patients, okay? ولكن ACE for ejection fraction less than 40. Okay. Now, rehabilitation therapy. Have you heard of cardiac rehabilitation?
سمعنا بها لكن ما شفناها بس.
طيب.
ما عندنا.
ايوه هي مهمه جدا وان شاء الله في الادفانس موديول اوف كارديولوجي حنتكلم وحاجيب لكم دكتور ادم ستارلون of the cardiac rehabilitation. Is a famous name in cardiac rehabilitation. حيوريكم what is cardiac rehabilitation, how important it is. It's really pivotal and essential and important وله كميه من البروجنوستيك يعني outcome في أنه if you rehabilitate patient post-acute coronary syndrome and if you don't, the difference is magnificent. Okay? فنخلي الأمر ده لاحقا. تمام. طيب. Now, it's important after we deal with the acute coronary syndrome and we treat the acute coronary syndrome to know that these there are some terminology around it. طبعا أنا I tailored this session basically in as F1. ولكن hopefully كل الناس حتستفيد. الترمينولوجيز المهمة around this revascularization stuff and vascularization stuff is the stunning, hibernation, remodeling, reperfusion, injury. And then the mechanical complication of acute MI. Now the stunning, hibernation, remodeling, reperfusion, injury. Let me leave all of them. Start with the reperfusion injury. What does that mean to you? Reperfusion injury.
This arrhythmia post opening of the
Yes.
total occluded vessel.
Yes, exactly. Arrhythmia. Okay. Or the most common arrhythmia or reperfusion rhythm is what? The most common. Idioventricular rhythm. Idioventricular rhythm. Exactly. وطبعا reperfusion injury is thought to be once you open the artery there will be an oxygen, restoration of blood oxygen, and that will form the oxygen free radicals which might damage the tissue ويحصل لك these kind of problems. Okay. من ضمنها idioventricular rhythm. There is another phenomena which is so famous and which represent one of the great nightmare of the interventionist, and it belongs to the reperfusion injury, and that is what?
No reflow after revascularization.
Thank you so much. Thank you so much. The no reflow phenomena. طبعا the no reflow, the people يعني intuitively كده بالظن الحدثي you feel it's just because of the distal migration of clot debris blocking the distal artery. No, it's not like that. حتى في trials they have put the occluder device عشان ما تمشي الدبري ولقوا إنه the phenomena the non-reflow doesn't decrease. So the non-reflow is not about mechanical obstruction by debris and the migration or distal migration of clots. It might be partial factor in the mechanism, but mainly it's because of the edema, okay, and the oxygen-free radicals and the influx of leukocytes in the necrotic milieu. فالقضية قضية معقدة, okay? But it belongs to the reperfusion injury. Another manifestation of reperfusion injury. Now we mentioned two. The third manifestation of reperfusion injury is
High biomarker.
high biomarkers, okay? I accept that.
I think it is stunning.
It's stunning. Thank you so much. It's stunning. So what is stunning? Stunning, if you look at this one here, in the normal circumstances, you have coronary flow and you have normal contractility of the muscle supplied by that coronary artery. Now, if I have a blocked artery or decreased perfusion, the heart will go into hibernation. And hibernation is thought to be protective here. That's why they call it a smart heart hypothesis. The heart is smart by going into hibernation, decreasing the metabolism, the consumption of oxygen to match the flow, because the flow is low. So let's be physiologically low profile. And in doing so, it prevents death of the myocardium. That is the hibernation. So hibernation is no flow, no contractility. Now we take a patient with acute coronary syndrome or coronary syndrome to cath lab, we open the artery, we restore the perfusion. Usually, once we restore the perfusion, we expect the contractility comes back. There is a time lag. There is a time lag. That time lag is defined as stunning. So stunning is defined as perfusion function mismatch. You have perfusion coming back, but the contractility is not yet coming back. Okay, that is stunning because it's reperfusion injury. The heart is still stunned somehow, is not yet back to normal. It takes few weeks and the contractility is restored along with the blood vessel or with the blood perfusion restoration. Okay, تمام. طيب في important concept you also have to know about, which is the cardiac remodeling. And cardiac remodeling is defined as a group of molecular, cellular, and interstitial changes that manifest clinically as change in size, mass, geometry, and function of the heart after injury. يبقى the remodeling is important. Why? لأنه it is a cascade of changes. بتحصل على different level, molecular level, cellular, interstitial, وعندها clinical manifestation. اوكي بتظهر في نحن في الايكو مثلا بنشوفها انه السايز بتاع الهارت بيتغير، الجيومتري حقته بتتغير، الفانكشن والايجكشن فراكشن بيتغير after the injury. بمعنى ايش after the injury؟ يعني patient had acute MI مثلا مثلا say last year, and he had no ischemia again, ولكن his heart continues to deteriorate in terms of function and geometry and size over time. That is the remodeling. Okay, that's the remodeling. طبعا الميديكيشن can retard the remodeling process ولا حتى مرات تعمل reverse remodeling. Okay, ولكن الremodeling انه after the initial insult the heart keeps deteriorating due to different factors. Okay, ومثلا إذا أخذنا the gross sample on the left, it's of a patient with MI, and you could appreciate that you have aneurysmal apex filled with clot. That aneurysmal apex, if you look at it, it will lead to changes, صح? بالpush and pull forces, changes in the molecular, cellular, and genetic elements. بيتغير الاركتكتشر, الهيستولوجيكال architecture of the heart. يحصل hypertrophy, يحصل fibrosis, يحصل thinning out, يحصل pull, يحصل splitting of the mitral valve annulus, وبالتالي functional mitral regurgitation. Functional mitral regurgitation leads to more dilatation, and more dilatation leads to more of functional MR, and so on and so forth. Vicious cycles and circles. Okay. فبالتالي look at the heart on the left, the echo, and there is a demonstration of the change in geometry of the heart from the bullet shape to spherical. طبعا spherical heart is bad. It's very bad, the spherical heart. And probably you have heard of the sphericity index that we measure in echo. Sphericity index is important measure in echo. بنحسبها كالآتي مثلا you see here, if you have this one, this part here, you see, is the longitudinal axis, and this is the horizontal axis. So the longitudinal axis over the horizontal axis. Usually it's more than 1.5. Okay, so if it's lesser than 1.5, the heart is start to be spherical and globular. So it's not, by the way, it's not about the ejection fraction. The geometry of the heart has a lot to do with the functionality. عشان كده ejection fraction don't stick to it so much. يعني مثلا يكون patient عنده ejection fraction 30 ولكن عنده globular heart. واحد عنده ejection fraction 15 ولكن the heart is still يعني not so spherical. He might fare better clinically than that patient. So it's not about the ejection fraction. It's about the sum of other parameters and features. Okay? Well, sphericity index is one important thing we measure for prognostication. Now, the troponin. طبعا troponin you have here in the course, and you have a lot. The troponin T, I, and C, and we are not using troponin C because C is isomer in the skeletal muscle and the heart, so it's not lack cardiac specificity. So we use T and I. Okay, I think في Sudan you are using I, صح؟ ولا T?
I mainly.
Even
I.
No,
Okay.
T.
T? Okay. معناته قد يكون في مراكز T وفي مراكز I ولا كيف؟
There is I, like Fidel.
Okay. فيديل بيستعملوا I. Okay. طيب, one important thing is that you have to know إنه troponin does not always mean necrosis. Okay. Yani in context of MI, we have necrosis. Necrosis means we have disruption of the cell membrane and the discharge of the cellular content out. عشان كده التروبونين بيكون the highest مع النكروتيك MI thing. ولكن it's not always the case. Sometimes بيكون just due to lack of permeability of the membrane, and some of the systolic troponin leaks out. So it could just be wound. لذلك الناس بيقول لك إنه mechanism are necrosis, apoptosis, necroptosis, and cell wound. Okay? يبقى it's not just necrosis. It's not just necrosis. Okay? ولذلك في مفهوم مهم جدا يا اخواننا نحن لازم نعرفه انه troponin بيحصل نتيجة acute coronary syndrome MI in particular, لكن بيحصل مع الستروك، بيحصل مع السبسيس، بيحصل مع البلمونري embolism. اوكي؟ بيحصل مع الرينال فيلير. صح؟ طيب is it cardiac لما يحصل مع هذه الاشياء الثانيه ولا it's non cardiac؟
It's non-cardiac.
Some of them cardiac but not coronary.
يا سلام, thank you so much. Yes, this is precisely the right answer. There is no such thing as non-cardiac troponin. خلونا to agree. كله بيجي من الهارت. سواء كان due to ischemia or non-ischemia. So it's better إنه ما نقول this is cardiac non-cardiac troponin. It's better to say ischemic troponin and non-ischemic troponin, both of which comes from the heart بدifferent mechanism. Either necrosis، وريتكم في ميكانيزم ثاني مثلا مع ناس الرينال فيلير قد يكون في increased permeability فبيحصل ليك للسيستوليك troponin out. لكن it all comes from the heart. In stroke it comes from the heart. Okay? In sepsis it comes from the heart. لكن it's non-ischemic injury of some kind. Subtle non-ischemic injury we don't know much about. Good. What are the complications of acute MI? And this is حقيقة the acute mechanical complication is a nightmare. You know the Darth Vader? Darth Vader, I think, is a character in Star movie franchise. I've never witnessed that movie. Death, arrhythmia, rupture, tamponade, heart failure, valve disease, aneurysm, dressler embolism, RV infarction. I don't think that's inclusive of all, ولكن يعني لا بأس. طبعا sudden cardiac death might be the presentation of MI مش كده؟ وربما في بعض الناس يقول لك 20 or 30%. I don't remember exactly the figure of MI. The actual presentation is sudden cardiac death. Arrhythmia وأكثر الأريثميا is the VTAC and AF. Rupture قد تكون free wall rupture VSR. VSR, don't say VSD, okay? Don't say VSD. VSD is ventricular septal defects. هو ممكن ولكن ventricular septal defect means congenital. This is rupture. So VSR, okay, ventricular septal rupture. Tamponade ممكن يحصل in context of acute MI وكده. Yes, it can. Heart failure. نعم. Yes. Okay. Valve disease usually takes time. صح? Valve disease, unless it's a acute papillary muscle rupture. Ischemic MR بيحصل over time. And functional MR due to the dilatation of the ventricle and remodeling بيحصل over time. They think that acute MR بيحصل مع papillary muscle ischemia and papillary muscle rupture, which is the most devastating complication ever. Fortunately, it's not common. يعني أنا papillary muscle rupture, I remember 3 or 4 times papillary muscle rupture. VSR, I have seen it relatively more than papillary muscle rupture. Okay. Free wall rupture is also not so rare. Free wall rupture, especially which wall? Especially which wall? Which wall is the most prone to rupture? The weakest wall of the heart is
apex. Apical curve.
The apical.
Okay.
Lateral wall.
Lateral. The lateral wall. Exactly. The lateral wall. أكثر الربشرز قاعد تحصل في lateral wall. Lateral posterior wall. Okay. Lateral posterior wall. Papillary muscle rupture, أكثر papillary muscle ممكن to rupture chances. Which one? Anterolateral or posterior-medial? Posterior-medial, right? Posterior-medial papillary muscle. Why?
Because it is
To the lateral wall.
يعني ischemia
Has ono supply?
Very good. Single blood supply from the RCA. لكن الانتيرو lateral has dual blood supply from the diagonal and OM. عشان كده protected. You have to have 2 artery occlusion to have rupture. عشان كده relatively protected, not like the mono blood supply of the posterior wall, posterior papillary muscle. Okay. Aneurysm formation. This is again a remodeling process that takes time. Mural thrombus that forms. Type. Now a question to you. Do you think mural thrombus or apical thrombus is more common with ischemic cardiomyopathy or non-ischemic cardiomyopathy? Is more common with ischemic, huh?
Yes.
Okay. طيب and I have different idea about it. It's more common in non-ischemic. dilated cardiomyopathy. Why ده أصعب سؤال على الإطلاق.
global hypokinesia.
Yes, maybe the globality maybe is one reason. And حاجة الثانية أنا I don't know ولكنها it seems so important, which is what that's my own hunch, so don't hold me to my words that إنه yeah إنه
Continue.
Yes. We have done a study. I was part of this study about clot formation in different form of cardiomyopathy. MR is protective. The more of MR you have, the lesser chance of thrombus formation in the apex because of the washing effect of the MR. Maybe.
No,
Yes. الحاجة الثانية اللي لاحظناها إنه non-ischemic cardiomyopathy harbors more thrombi in the apex than ischemic cardiomyopathy. أنا أفتكر إنه the presence of trabeculation and the preserved thickness is important for thrombus formation. يعني مثلا الآن you think إنه الclot formation مع الMI مع الkinetic dyskinetic apex بتحصل initially in the context of MI ولا later on لما يكون في aneurysm formation؟
بتحصل initially.
Thank you so much. The vast majority of thrombus formation in context of MI بتحصل في few weeks after MI. لما يحصل remodeling ويحصل aneurysm and thinning out of the apex, surprisingly not much of clots are there. يبقى بالتالي seemingly أنه the preserved wall thickness is an important factor in apical thrombus formation. ولأنه DCM is always preserved thickness لأنه remodeling حقه ما فيه much of scarring aneurysmal formation زي ما بيحصل في ischemic cardiomyopathy. For chances of إنه it forms and reforms clot is more than ischemic cardiomyopathy. Okay?
Yeah, Dr. Hatim. في الاسكيميك ثرومبس فورميشن ممكن due to الباثوجينيسيس بتاع الانفاكشن او الاسكيميا بيحصل هايبر كواجولابل ستاتس in general، فممكن يكون يعني ده الكوز بتاع انه يحصل لنا الثرومبس فورميشن.
Yes during ال MI you mean صح؟
Yes, I mean during MI.
Yes I agree with you. لأن هي في بعض الناس بيقولوا إنه ال MI يعني induction of the coagulation cascade is more of systematic and there is systematic inflammatory process, so it prone the entire body to clot formation. ممكن yes I agree. ولكن بس just in your practice try to do and you can research this area. It's still fertile, by the way. Ischemic cardiomyopathy versus non-ischemic cardiomyopathy in terms of thrombus formation. You can go for this one. Now, RV infarction is an important complication and probably you don't want to see. inshallah يا رب ما تشوفوها لأنها مزعجة خلاص. فالpatient بيكون hypotensive, extremely hypotensive. Okay? The only thing you have in your hands is what? Fluid and sometimes inotropic support. Fortunately, reversibility is not bad. RV it can bounce back. RV is not like the LV. السكارينج فيه قليل والirreversibility فيه قليلة and there is a good chance إنه it recovers. Okay? تمام. Now what is this? Tell me, what do you see here?
VSR, very big VSR. Moscow. VSR.
VSR. وعاه ايش؟
aneurysm. ما في حتى الوول بودن على الار في ولا دي trabeculation.
Yes, this is trabeculation. This is trabeculation. وبعدين لأنه ال VSR مرات بيكون بيسموه snake like serpentinous kind of defect. يعني it's not straight from traversing the wall. لا مرات it cracks into the muscle and it goes spirally and back into the cavity. بيكون معقد جدا، معقد. وطبعا ال VSR clinically is so expressive فالبيشنت بيكون عنده thrill واضح وميرمر واضح. Not like ال MR. ال MR of papillary muscle rupture tends to be clinically silent. لأنه acute, and when it's acute the murmur is not so loud, thrill does not exist. الإيكو حتى الترانثوراسيك إيكو might miss it, and T is the way to go. لكن ال VSR is important. لكن ال VSR is so many times missed. I remember I missed VSR and I still so pissed off with myself for missing it, because the clinical data was actually lacking. They did not provide me with adequate data. They just want to, they ask for echo for patient, regular patient of MI, okay? And we did the echo the regular way. Patient keeps deteriorating. And then we focused on mechanical complication. We found, there is VSR. When I go back in the initial echo, I find, glimpses of VSR, but we missed it. Why we missed it? We missed it because we did not focus on it. انت لازم you take the color sector into the septum. How many times you take the color sector into the septum? How many times? We don't do it routinely. صح؟ نهائي. You don't do it routinely على الإطلاق. ولذلك try to make it a habit يا أخواننا. Whenever a patient with MI, any MI, and I think it costs us nothing, we take the color sector into the septum. Okay? It takes يعني ما حد كلفنا حاجة أبداً. Okay, so this is important. لكن لما يكون البيشنت يقول لك إنه مثلا he is deteriorating, you have to definitely focus on mechanical complication and exhaust every single measure you can عشان to define which mechanical complication is there. طيب, now what is this? Papillary muscle rupture. Look at this one here. How you see papillary muscle rupture? You will see a small piece of meat attached to the cord. A small piece of meat that is mobile attached to the leaflet that goes into and out of the left atrium, like this. The yellow arrow, like this. You see? See this one?
Oh my God. It's very...
You see this one, right? This it doesn't, it's not the leaflet. That's, huh? Yes, this is severe. The mitral regurgitation is an eccentric because of the flail anterior leaflet. Okay. And what is this? The LV gram on your left and the echo on your right for the same patient.
ما جاء في الصورة يا
This is the LV gram.
lateral wall.
LV. Lateral wall rupture. You see the dye is leaking out of the LV cavity in the LV gram from the lateral posterior wall. And when they do echo, or when they did echo, you see the lateral wall, there is rupture. You see, this is the rupture. I'm going to point on it. This is the rupture here. Okay? Good?
Yes.
What is this?
أنا سامعة يا جماعة صوت، أنتوا سامعين؟
No.
Yes, I'm so sorry. I was on the mute. Okay, I'm so sorry. I ask you why did I put Takotsubo among cardiac emergencies? Because 2% of acute coronary syndrome in general is Takotsubo, and 5% of acute coronary syndrome in women is due to Takotsubo or turned out to be Takotsubo. And this is a lot. معناته بين كله 50 في واحد وبين كله 10 female with acute coronary syndrome في واحد. It's a lot. أنا ما أعرف طبعا قد يكون في geographical variation. Yes, السودانيين أنا أتوقع إنه عندهم stamina. They are strong and they live with death day and night. فبالتالي التراجيديز ما حتكون مؤثرة فيهم كثير ممكن. ما أعرف أنا لكن it depends. التوليرنس خالص التوليرنس له أثر.
Yes, it's strong.
strong, very strong. Yeah.
النظام الصحي
إحنا ما كانوا عايشين بالضغط الحالي ده الحمد لله.
لكن انا اتوقع اي دبان بنسمع قصص كثيره في الحله وكده عن انه مثلا يقول لك والله يا اخي توفت بعد زوجها او الزوج توفى بعد ولده او بعد زوجته. I think this is all Takotsubo.
Yes.
مش كده؟ most likely this is Takotsubo. لانه يعني psychiatric distress will not kill you right away and directly. It has to do it through حاجه more organic and more conceivable like the heart. وما في سبب تاني. يعني هل PE؟ ممكن PE لكن more likely Takotsubo. لذلك التاكوتسوبو is underestimated لأنه الناس ممكن تموت قبل ما تجي بتكون ماتت. ناس كتير صح؟ مع whatever tragedy, whatever disaster and stuff like that.
ماتت بالحرقة يعني.
ماتت بالحرقة بالضبط كده. طيب it's important by the way in Takotsubo you know that there is physical stress and psychological stress. وقالوا إنه physical stress is more identifiable in males with Takotsubo and psychological stress is defined more in female with Takotsubo. Seemingly that الرجالة are more stressed physically by physical stuff يعني الجوع والعطش والديزاسترز وكده. لكن النساء might be influenced as robustly as by psychological factors. Okay. anyhow an ECG بيكون فيه features of MI sometimes ولا ST segment depression, Q wave prolongation, QT prolongation, different ways. Troponin بيكون elevated, الإيكو بيكون ballooning of the apex. Okay. And ولكن في variance صح؟ It's not only apical ballooning. It's not that it looks like this one. It's not necessarily like B, apical ballooning and hypercontractile base. في different variants. في mid cavitary اللي هو الميد segments بتكون هي المشكلة. mid cavitary Takotsubo. في apical Takotsubo which is called reverse Takotsubo. And we have reported a case of reverse Takotsubo after induction of anesthesia in a young lady. And there is focal Takotsubo, just regionality, just like ischemia, wherever it hits. ولكن the typical form of Takotsubo is apical ballooning. ولكن there are variants. Okay? تمام. Now, I want to show you this one here. This is a patient with acute MI. Was in hospital and was discharged.
الصوت ما واضح يا أبو.
الصوت ما واضح؟
واضح شبكتك يا
واضح
سهير.
شكله دي شبكتك يا سهير.
ايش يا سهير شكلها شبكتك بالكلام يعني ديمقراطيا يتحسم الامر. طيب البيشنت دي كان severely shortness of breath with exercise. His ejection fraction was 35, I think, and he had mid LAD and apical dyskinesis. Okay. They investigated, they investigated this patient and they did exercise. echo and see what exercise echo reveals. It reveals إنه في LVOT obstruction with MI. What is this LVOT obstruction with MI? What is it? Strange. LVOT obstruction with MI. Have you come across this?
Rupture of mitral.
No. Strange, yes.
أول حاجة ما في LVH. Okay, there is no LVH. لكن there is SAM and there is dagger shaped signal and everything that looks like hook'em, and there is no hook'em, and the ejection fraction is 35-30. There is hyperkinetic base and hypokinetic mid and apical. So the hyperkinetic base is compensating for the hypokinesis down. And when you have hyperkinetic base, vigorous contraction, ممكن تخلق SAM. ويعمل لك LVOT obstruction. And this is relatively common. The last case I have seen was a week ago. A patient after revascularization with massive MI, anterior MI, was persistently hypotensive. And they were taking him to ECMO. Like they asked us to do TE. We did TE and I found SAM. يعني the anterior leaflet was flying into the LVOT, obstructing it. I said, okay, you know what? Don't please, يعني backtrack on inotropes. He was on maximum inotropes. I asked them to, slow down on inotropes. طبعا they didn't like me for that because the patient was extremely hypotensive. So how come I backtrack on inotropes? I said, please give fluid instead and let's just tailor down the inotropes. They didn't believe me. وطبعا خلاص, it's my opinion as an echocardiologist is not well taken, and I left. لكن the registrar, I advised him to do it, and he took my advice and he did it. He kept the patient on fluid. In the morning, the patient was on no inotropes and fluid was given like 3, 4, 5 liters, and his blood pressure maintained normally and he was discharged. So just this diagnosis saved him from ECMO, which would have otherwise killed him actually. Okay, you have to be careful about your echo analysis of all things, and SAM obstruction in context of MI is not uncommon. Okay. When we say we have a decompensated heart failure, a patient present with decompensated heart failure, what do we mean? Decompensated heart failure معناه البيشنت جاب shortness of breath or apnea, PND, swelling, loss of appetite ولا حاجات تانية صح؟ Fatigability, stuff like that. The most important thing in decompensation, إنه we treat the decompensation and we try to probe into what causes the decompensation. So look at this list here. These are the famous causes of decompensation. From تقريبا 1,250 patients, they found that infection is 22.7%. Poor medication adherence, 29, almost 30%. Increased ingestion of sodium and water, and along with this non-steroidal anti-inflammatory and other medication is 9%. Acute valvular disease is almost 7. Arrhythmia, 12.5, pulmonary embolism and others. So the most important 4 are infection, adherence, sodium and water, and cardiac arrhythmia. Okay. These are you have always in your history to try to elicit what brings this patient to hospital today or tonight. Okay. This is important. And decompensation is important. Why? لأنه شوف طبعا this is a very famous slide from ACC back in 2005. You see here the disease progression according to the decompensation. أي decompensation dips you down and never back again to the baseline in terms of prognosis and mortality. أي decompensation, if treated and you are discharged, you are never like back. You are never like before in terms of mortality. This is important, and therefore every decompensation brings you closer to death. And therefore, it's so important to prevent, not to treat decompensation. It's more important to prevent than treat decompensation. Type. Last slide. What do you think about this one? Left and right, they mean the same thing. ECG. Isn't it? I might zoom it in. What do you think about this?
Atrial fibrillation.
And this
Fast
one?
ventricular response. It's more faster.
And this one? Yes, also AF.
It's fast.
AF is the most common arrhythmia encountered in medical practice. Agree? Yes. If the active arrhythmia you are likely going to deal with here atrial fibrillation and fast AF. Okay. So if a patient comes in ER with fast AF, يكون همك الأساسي أنك أنت you take this ECG back in clinical context, how the patient is. إذا كان فيه hemodynamic compromise أو he's symptomatic, then you have to act fast. And acting fast means what? Acting fast means what? What are you going to do in a patient with fast AF and low blood pressure?
Emergency cardioversion, electrical cardioversion.
Okay, so cardioversion. Type. Are you going to jump in cardioversion and you take the pads right away, or are you going to do something before?
No.
TOE.
TOE.
No, ما في. إذا في if there is time, but otherwise I will give heparin 5,000 injection and then I will cardiovert. But if the patient can wait, we will try to control it by pharmacological drugs. Metoprolol.
Okay, like what? Metoprolol and?
If the LV function is good, أحد verapamil. Yes, metoprolol verapamil.
Okay.
عندنا injection طبعا is slow acting. يعني عندنا injection لكن slow acting. We'll try it also. Yes.
Okay, good. طيب بس في نقطة بتاعت إنه we can do cardioversion if the patient is hypertensive without going for TEE. Do you agree or disagree? هي طبعا it depends صح؟ يعني مثلا أنا I agree إنه إذا البيشنت كان
if you are in crash, yes.
I will not wait لأنه yes الحالة إنه ما في time صح؟ There is no time يعني حتكون قضية صعبة شوي. ولكن يعني أنا أتذكر جاتنا patient that was like maybe 10 years ago. She had, we don't know. She is an Asian lady, young lady. We don't know her background. She came in shock and AF was like approaching 200. Okay. We're nearly missing her actually. The consultant told me, you know what, go ahead with cardioversion. I said, no, don't please, let's do TE. There is no time for TE. I said, okay, let's try, like you said, just control the rate. Okay. Fortunately, with beta blocker, heart rate slows down. Okay, slows down. Then next morning, we planned cardioversion. The circumstances was much better. We did TEE, and there is not only LA apical clot. There was a large LA clot covering half of the LA cavity because of severe mitral stenosis in this lady. Yani, LTE is important if you have time. Lakin, if it's emergency, so you have to weigh the risk and benefit. And if a patient is crashing in front of your eyes, there is no time to do anything, just go with the risk. Okay? Tamam. This is AF. Type. What about this one here? What is this? What is this ECG? One of the probably most important cardiac emergencies you are also likely to encounter is this ECG. So what is it?
Complete heart block.
Yes, this is complete heart block. And I wish always whenever you mention complete heart block, you tell me about the escape rhythm. So it's complete heart block with What kind of
Which one?
escape rhythm? What kind of
Junctional,
escape
yeah,
rhythm?
superficial.
Junctional escape rhythm. That's important. Why? Because if it's junctional escape rhythm, I might relax, but if it's ventricular, it's hard to relax. The broader, the slower the escape rhythm, the more likely the patient will crash if he is not already crashing. Okay? يبقى junctional escape is better than ventricular escape. Like this one here, it's junctional escape. يعني you can حتى في ناس they live nearly normal life span with complete heart block junctional escape. Agree or disagree? Yes. مثلا babies of mothers with SLE who get congenital heart block بيكون junctional escape and they live nearly normal life span. لكن acute sort of blocks اللي بتحصل الاسكيب ريذم بتاعها بيتعدد ventricular or junctional ولا هيسيان وممكن تكون في مشاكل. لكن كمان الجudgment is important here. If you have complete heart block, again you take that ECG into the clinical context. If the patient is symptomatic because of bradycardia or hypotensive, chest pain, shortness of breath, stuff like that, low perfusion, you have to act immediately. And by acting immediately, we mean what? هنا حتعمل ايه؟
Temporary pacemaker. Temporary pacemaker.
طيب اذا مثلا التمبرري بيس ميكر برضه ما هو نفس الكلام اللي احنا قلناه سابقا مع التي takes time لحد ما انك انت you take patient to انا ما اعرف انتوا ما بتعملوها في الكاثاب you can do it bedside لكن sometimes it takes time يعني during this can you buy time لحد ما تعمل تي بي ام؟
Yes, yes.
Transcutaneous, yes. You can use transcutaneous. Transcutaneous طبعا موجودة في كل المونيتورز في الفيتشرز بتاعت الترانسكيوتينس بيسنج. So you can buy time لحدي. بس طبعا مشكلتها انك you need to sedate the patient لانها external and painful. Okay? ف you can. تمام؟ هل في medication you can try prior to transvenous pacing? Can?
Atropine.
Yes, you can try atropine, you can try dopamine. Yes, you can try with medication. Okay, so this is important. Now, last part of the cardiac emergencies you are gonna see is the cardiac tamponade. The cardiac tamponade, you are gonna see a patient with effusion that most likely is large, compressing. Like you see on the image on the left, I'm seeing RA inversion. RA inversion, right? They call it RA inversion. RA inversion is not specific of tamponade. Is not specific of tamponade. لكنه sensitive. لكن the specificity of RA inversion increases if you time it to the cardiac cycle and you see that the RA is inverted more than 1/3 of the cardiac cycle, more than 1/3 of RR time or RR interval, that is specific of tamponade. يبقى in RA inversion, don't go by just eyeballing. Try to time it and see how much it occupies in the cardiac cycle. لكن as to the RV free wall, that is so specific. It does not depend on cardiac cycle or the timing or never. If you find it, the patient is in hemodynamic, in echo problem or hemodynamics is likely to be of tamponade physiology. This is RV collapse, okay? RV collapse. And you see it here in M mode is even better demonstrated in M mode, and in M mode is better demonstrated than 2D. Why? Why M mode demonstrate RV collapse better than 2D? Why?
Respiratory variation.
It's still immature.
لا أنا I wish you understand my question. أنا قلت لكم إنه why M mode demonstrate RV collapse better than 2D.
عشان
More
temporal
temporal
resolution.
resolution.
Thank you
temporal
so
resolution.
much. Exactly. That's the answer. More temporal resolution. Okay. يبقى this is one of the things that M mode is really important and superior to 2D. And the Doppler, also you see here the mitral variation, respirophasic variation, in the mitral and tricuspid. Usually the variation that amounts to tamponade across the mitral is how much?
45%.
How much?
25.
25%.
25. More. And the tricuspid?
40%.
40. Good. And what is this here? IVC? What is the IVC?
Dilated, not collapsible.
Very good. So
Share.
plethoric IVC, when it's dilated, non-collapsible. Now, if I ask you one question, which of all these echo feature is the most consistent with the clinical presentation of tamponade?
The M mode.
RV.
RV collapse.
RV collapse. No.
Respirophasic junction.
هي مثلا انا what I mean is what يعني let's say انه قالوا لك اختار one echo feature.
IVC.
Okay.
IVC.
Exactly.
IVC.
The IVC. The IVC.
IVC.
Yes. لأنه the IVC is كل الفيتشرز بتاعت التامبونات الثانية it boils down to what? It boils down to increasing the venous pressure, which is the IVC. And increasing the venous pressure translate in clinical tamponade, along with the decrease in the cardiac output and all of that. Okay. يبقى أهم features في نهاية الأمر هي ال IVC. بمعنى ال IVC can be important rule out. Let's say أنك you see all the typical echo features of tamponade, لكن عينت لل IVC لقيته small and collapsible. Patient is clinically stable. You can rule out tamponade. Whatever you see in echo data, IVC is so important. It's the most one that is clinically relevant is the IVC plethora. لذلك it's so important in echo, in أي tamponade assessment, you study the IVC so well. You have to do it so well. Okay? And what are you going to do for this patient? Precardiocentesis. And how are you going to do that?
The cath
Are you going to go?
Cath lab.
Okay. So are you going to do external blind? ولا you are going to do echo guided ولا fluoro guided?
With measurement of the pressure.
So you are going to do it what? Fluoro guided?
Fluoro guided.
Fluoro guided. Fluoro guided is fair. You can do it fluoro guided. And when you see the wire is looping around the heart, معناته you are in the precardium. Yeah, you can do it, no problem. ولكن the best way of doing it is what? Is echo guided.
Echo guided.
Yes, echo guided. It's the best way. لأنه it shows you the needle and you go and you pierce and you drain and you see that the fluid is gone, everything. It's so great, the echo. The only problem with the echo إنه شنو? إنه the echocardiologist has to be interventionist or the interventionist has to be the echocardiologist. يعني it's better إنه لأنه الprobe والneedle is held by the same operator. Okay? فلأنه أنت you put the probe. طبعا الprobe has to be sterile. Okay? في sterile sheath بتركب في البروب. Okay? عشان تخدها على الchest after you يعني drape the chest. وبعدها تخد البروب وبتكون ماشي بالنيدل when you are seeing your needle going into the precardial fluid. Okay? And then you aspirate. يبقى معناتها one hand with the probe, one hand with the needle. نحن مرات بنعملها شنو لأنه نحن شوية كده sophisticated بسبب الستافينج الكبير. فبتلاقي الإيكوكارديولوجيست is taking the probe and the interventionist holding the needle, okay? And you put the probe for him and you ask him to go and proceed. Okay, yes, I'm seeing you. No, I'm not seeing you. Change, stuff like that. ولكن usually أنا شفتها في أماكن كثيرة the same operator is doing the two stuff مع بعض. Okay? فما هي ما صعبة يعني بسيطة. Okay? لكن the echo guided is the safest. دلع شديد.
luxury.
لذلك نحن هنا لما نمشي
نحن
UK
هنا
ولا
لما
كده.
تلقى monitor that is enough for you.
Oh yeah, I know, yes. أنا أتذكر عندنا one of our registrar went to UK, okay, and he was covering an on-call. Then they called him in ICU. They asked him, we have patient with shock and we are suspecting tamponade. But he came and he did the echo by himself. And he found that there is tamponade. And he stood up and told them, I have a tamponade case. Okay, so what do you need to prepare kits and stuff? He said, what? Yes, what do you need for pericardiocentesis? So they assume that he is gonna do the pericardiocentesis. هو طبعا he recently came from our center ومدلع جدا. يعني نحن, if you are suspecting a tamponade, if you are a registrar, you are going to call the echo fellow and the echo consultant who are
So
going to
we
come
are UK level.
Yeah, exactly. Who are going to confirm you have tamponade. Then you are going to take the patient to the cath lab. The consultant interventionist with his fellow will come. And the consultant echocardiologist with his fellow will come. That one will do the echo part and this one will do the interventional part. Yes, you see? فقضية شوية كده مدلعة فعلا يعني. ولكن انتوا are doing it right لانه الريسورسز كده الريسورسز بتحكم مرات الواحد واحسن انه الواحد يكون a jack of all trades يعني احسن لانه انت لما تكون cardiologist with many skills is better than انك انت you kind of forget about كل الحاجات بقيت بس عندك فوكس واحد ما بتعرف غيره. This is bad. This is so bad by the way. يعني هسه نحن though انه ممكن نعتبر نفسنا we are advancing echo ولكن something has taken from us اللي هو the big picture of cardiology. It's not good يعني فأحسن واحد يكون شوية a jack of all trades إلى حد ما. Okay. by this I conclude.
مع الاستراليزيشن يعني فبنشتغلها بيكون فيرم ذات وهاب لارج فيوجن. طبعا عندنا لارج فيوجن بيكون ماسيف في الغالب يعني. أيوه. انا اخر واحد دسه 60 something سنتيمتر فبنخش بلايند صراحه. لكن ما قاعد اجل يعني one need one man break فعندنا مشكله يعني الريسورسز وكذا فبنشتغلها في الغالب النازل بيشتغلوا بلايند كلهم يعني.
ما عندكم ايكو صح؟
في ايكو لكن ما في ستيرايل بروب وكده فعشان كده يعني فبنسحب بنأكد بعد بنعمل ايكو بوست بريكارديوسينثيسيس تكون فعلا انك فعلا يعني
معناتها you go blind صح؟
كلنا قاعدين نمشي كده.
you go blind. اوكي. هي طبعا باي ذا انا اقول لك حاجه. yes if the effusion is large لكن مرات مثلا لما يكون localized and posterior and كده small moderate is not that big احسن انك تكون ايكو guided. ايوه بالضبط.
ما بنشيله الا عند
لكن if it's large exactly
الغالب بيكون emergency يعني في يونت زي دول ما بيصبروا.
ايوه yes exactly. Sini.
Under semi
yes. Fluoro is fine by the way. Yeah. Fluoro is not bad. It's not bad at all يعني. Fluoro is reasonable. هو زمان كان بيعملوها ECG guided. You know how? يعني بيخط ECG clip على needle. Okay. وبعدين they go inside. طوالي بس advancing the needle. When he gets PVC he backtrack. معناته ضرب الميوكارديوم. معناه قرب بس يطلع شوية كده معناه this is the precardium. اوكي فكانت اسمها اي سي جي جايدد. ولكن طبعا برضه الاي سي جي جايدد لانها تعتمد على انك يو هيت ذا مايوكارديوم اند ذن يو موف باكورد بقت برضه ما بيعملوها. هسه الستاندر هو ايكو جايدد او فلورو جايدد لكن يو كان جو بلايند مع اللارج ايمرجنت فيوجن وكذا يو جو بلايند خلاص ما في حاجه. اوكي تمام. Thank you so much. وإن شاء الله يوم السبت القادم حيكون عندكم مع دكتور حسين هدو exercise ECG. Okay.
That's great.
Yes. Okay. طبعا exercise ECG رغم إنه downgraded لكنه مهم ليه؟ مهم لأنه حتى هو part من الاسترس بتاع الإيميجينج الثانية. يعني part من الاسترس من الاسترس part of the nuclear. part من الاسترس بتاع الايكو. it's important you know exactly فايدته شنو يعني. ما زال عنده value عالية جدا جدا. okay. It's important. That's it. Thank you so much. Thanks a lot.
Concentrated dose of emergency.
Thank you so much. يعطيكم العافية دائما يا رب إن شاء الله. Thank you so much. الله يبارك فيكم إن شاء الله.
The recorded lecture, we are going to receive it.
Yes, I'm going to send it to you.
Thank you very much.
Thank you so
Also,
much.
yeah, boss, I hope you have recovered the ECG, the X-rays. The X-ray
والله ما زالت محاولات البحث عنها جارية لكن ذكرتني.
It was very important and it was very helpful. أنا really يعني I hope you can recover it.
جدا خلاص إن شاء الله بإذن الله. وإنتوا حاولوا زي ما قلت لكم حاولوا أعملوا bank of some kind عشان تحفظوا فيه الأشياء دي عشان ما تروح.
Yes.
عملوها وعملوا لها تبويب وتنظيم وهكذا.
اوكي ان شاء الله.
تمام جدا. يلا في امان الله ان شاء الله.
امان الله.